Questions, please submit your questions in the chat box and I will relay them to Cody as we go along. And just another last reminder, we are no longer doing the certificates of participation or completion. So those are no longer available. I think with that, I will turn it over to Cody.
Yeah, thank you. Good afternoon, everyone. My name is Cody Stanley. I am the 1915I Program Administrator. And if you're not familiar with 1915I, we're about to find out. This presentation, just to give you a little orientation to it from the perspective that it's given. It's kind of from the perspective of someone that doesn't know very much or has never really heard of 1915I. Kind of goes over all of the bases, and there's a lot more information on our webpage that goes into more details on the many areas that I'll be going over today. So what is 1915I? Well, 1915I is a behavioral health and support service available for people in their homes in their community of choice. It's a non-traditional Medicaid and home and community-based service. It supports people in their homes. So the idea is keeping people and getting them out and keeping them in the community and their places of choice. The name 1915I, I get this question actually quite a bit. It actually comes from Section 1915I of the Social Security Act that has to do with home and community-based services. And then and I should also point out that this presentation I'm going over is also located on our main 1915I webpage, which I'll throw in the chat here afterwards so you can access it at any time. But this link here that you'll see in this presentation takes you to that and really goes into the nitty-gritty details of that section of the Social Security Act. The basis for 1915I, kind of what I like to call the DNA or the foundation of it, is what's called the State Plan Amendment. Each state has to submit a state plan amendment to be approved by the Centers for Medicaid, CMS. The approval is good for a 5-year period. And then after that 5-year period, you resubmit the state plan amendment for renewal. Currently, our 5-year plan period, we're right in the middle of a renewal right now. We had public comments on it back in March, and now it's been submitted to CMS, and we're in communication back and forth with CMS, doing the little tweaks and changes and things like that. Also on this webpage, there's the links that take you to CMS's website. So if you wanted to see the kind of the master plans and all the different tools and stuff that CMS has out there for state plan amendments, you can as well. So how is 1915I structured? Well, federal rules establish the structure of 1915I state plan amendment benefits. Then within that structure, each state is able to establish the benefits and define their own target population, eligibility criteria. There are certain requirements that do apply to all 1915I state plan benefits, such as the home and community-based service settings. Those are pretty much universal. But the states have a lot of ability to mold and create their 1915I plans how they see fit. So if you ever start looking at other states' 1915I, you'll see them name different things, see them have different services. That's why. 1915I individual eligibility criteria. Applicants have to meet all the following eligibility criteria for 1915I approval. 1915I serves members of all ages. Members must be enrolled in traditional Medicaid or Medicaid expansion. 1915I looks at the household income and that it must be at or below 150% of the federal poverty level. Members must have at least one qualifying behavioral health diagnosis and functional limitations as shown either by the HUDAS or the DLA. And then finally, members need to reside in a home and community-based setting. meaning they, can't live in an institution. And an example of an institution would be hospital, nursing home, jail, or prison. Diagnosis verification. If an individual is getting served by a human service center, they probably have a diagnosis on record. If they're not, they can get a printout from their medical record listing the qualifying diagnosis. A professional can diagnose per their licensure. And also, let's say they have on record that they do have a diagnosis. A verifying staff person from the medical entity can verify as well. So we try and keep it as broad as possible and make it as malleable as possible so people can get the diagnoses on the application as needed. There's a couple ways to apply for 1915I services. On our main 1915I webpage, we have the application. That's the SFN 741. That's the official title of the 1915I application. We suggest the best way is to fill out the application and then email it to applyforhelp@nd.gov. If you want to, you can also mail it in to the customer support center, or you can submit it in person to a human service zone office. And again, on the link webpage here, we have the link to the human service zone office map so that people can look up where their human service zone offices are. The human service zones process all 1915I applications. As we said, the application should be submitted directly to the zones via the instructions, and that's the apply for help at nd.gov being the best one. And then medical services, which is the department that 1915I is housed in, is responsible for ensuring that zone staff are trained on 1915I policy, and also that we are in communication with them as well as any needs arise that come up. Just kind of pull the curtain back a little bit and see how we manage the 1915I individuals. Dynamics is the name of our eligibility system. This is where the eligibility workers were enter in all of a member's 1915I administration information, the application, HUDAS, forms like that. It's where we track the active approved members who've been connected with the care coordinator, which we'll get into that here in a second, members with plans of care. Again, we'll go over that here a little bit. The 1959 navigator also works within Dynamics to keep track of and help individuals find care coordination. We have an active list in there of the members that have been connected with care coordinators and that have not, and those that haven't after so many days. Our navigator reaches out and starts working with them to try and get them connected to services or service provider, I should say. The state programming staff, there's 3 of us on the state side. Myself, I'm the administrator. Then we have Lori Gerard, who's our 1959 specialist, and Alexis Field, who is the 1959 navigator. We each have our own specific duties and responsibilities, but also there's a lot of overlap as well. We like to make sure that there's a lot of cross training to make sure that coverage is good. So that way, no matter what, someone is kind of available and able to answer and jump in and help answer a question for a member or, an outside entity that's kind of engaging with 1915I. Also on the team as well are the medicated expansion staff. These are Blue Cross Blue Shield of North Dakota is what is called our managed care organization. They're the entity that manages the navigation for the expansion members. So that's the outline of the programming staff at the state. This is kind of a layout of a member's journey to 1915I services, kind of walks them through, they fill out the eligibility application, they submit that. Then eligibility is determined by a zone worker. Then a member will connect with the care coordinator, and the member and the care coordinator work on a person-centered plan of care. And the care coordinator connects the member to the different services that they need. And then those entities, those providers begin providing the services. So that's a flow of how idealized how the 1915 I process will work. At the core of 1915 I are the care coordinators. Care coordinators really assess a member's needs for services, connect a member to needed services, and they ensure services are delivered properly once they start. As we stated here, it is the core service of 1915 I. All 1915 I members have a care coordinator, and actually, if they go 90 days without having any services, which means they go 90 days without working the bare minimum, at least meeting with their care coordinator once, they're not actually eligible for 1915 I anymore. So it's important for the member to stay in contact with the care coordinator. And the care coordinator is also the nexus of communication as well, ensuring that the member, obviously, but also if there's parents or guardians involved, if there are other team members, that they're all communicated with what the member wants and needs are going forward. We really stress for anyone that's interested or wanting to know to provide care coordination or what care coordination is about under 1915 I to really read through our care coordination policy. It's a lot of time has been spent on this policy by myself and my predecessor over the last 6, 7, 8 months, really fine tuning it and making it clear what care coordinators can and cannot do. So we really push making sure people understand and follow that policy. And again, there's a link here in the slide, and I'll show you where that stuff is afterwards as well. The system the providers use for writing plans of care, doing case notes, referrals is TheraP. We are also in the process of expanding the functionality of TheraP for 1915 I here in the latter part of 2025. We'll hopefully be getting, knock on wood, cross our fingers, everything works out right. We'll get billing for our providers set up through TheraP. That's a big goal that we're going to hopefully get done. Again, that's if everything lines up right, which I think it will, but things happen. Referrals are done through there, like I said, case notes. It's a very functional and versatile system that we use. And the question arises is, how does an agency accept a care coordination request? There's a variety of ways that this can happen. A member can contact an agency directly, because when a member is approved, they get a letter saying you've been approved for 1915 I services. The next step is to contact a care coordinator, or they could be connected through the 1915 I navigator, reaching out. Once that happens, the care coordinator will visit with the 1915 I member to see if they can provide the services, because some of our service agencies are, more specifically fine-tuned for certain populations. So it's making sure that there's the right fit as well. Once the agency has confirmed, yep, this is a good fit, we're good to go, let's rock and roll, they fill out what's known as a care coordination request report form, and this is a fillable form on our 1915 I webpage. What that does is that notifies the 1915 I administrative staff that this member has picked said agency. We then go in, look up that member's stuff and dynamics, and then take all that needed information and plug it all into TheraP. So that way, when the care coordination provider goes into TheraP and needs to know, for example, the person's HUDA score, it's all there in TheraP and they can access it that way. When it comes time to onboard new members, the care coordinator goes over the member's rights and responsibilities. They work with the member to identify and secure any supports the member needs to participate in care planning. Basically anything to kind of help communicate and get the member to understand the process. They ask the member if they're working with any other care coordinators or case managers and any other programs for example, just to make sure there's no duplication of services. And then finally, they set up a meeting to set up a time to go over and create the plan of care, identify what we like to call the who, what, where, and when, ensuring all along throughout this whole process that a member's preferences are guiding this entire process. This next slide we have, I won't read the whole thing, but uh, a lot of our members don't have guardians, but it isn't uncommon also to come across a 1915I member that does have a legal guardian. When that happens, the care coordinators need to make sure that the guardian is involved in all the processes or points in the process where their, consent and signature is needed as well. And this just kind of walks them through that process and is really for the providers to help them understand that. The care coordinator has 7 primary roles. We won't drill down deep into all of these at this presentation. There is on our trainings webpage, which we have the link here. If you click on that and then go to the on-demand training opportunities section, there is a care coordination onboarding training that all care coordinators have to take. And it's on our webpage. So not only can care coordinators take it when they have to, but anyone has just general questions or curiosity about care coordination can take that. And that training really spends a lot of time delving into these 7 roles of the 1915I care coordinator. So if you wanted, I would strongly suggest checking that out if you're really, kind of curious of what the care coordinator's primary goals are and how they kind of flesh those out and work out in those areas. A key part of 1915I's, the care coordinator in 1915I is monitoring and following up activities. Care coordinators are responsible making sure the members, POC is our acronym for plan of care. So if you hear me throw around POC, that's what I'm talking about, is the plan of care. Making sure the members' plan of care is implemented appropriately, that the members are receiving services, and that the services are meeting the members' needs. The care coordinator does this, and this by far isn't an exclusive list of everything they do. But first off, and most importantly, they talk with the member and the people that the member has chosen to participate in the care planning. They read the members' service progress case notes monthly, which, if you remember back to the provider case management system THERAP that we choose to use, the care coordinator, and I won't go too deep into the weeds of this, but the care coordinator in THERAP has the ability to go into the service provider. So let's say the member has peer support. The care coordinator has the functionality in THERAP to go into that member's peer support provider and read the case notes that were put in by the peer support so they can see what's going on, what services are being done. And then this last point is a policy requirement that they, at a bare minimum, have to meet with the member at least once a quarter. And that's kind of the bare minimum. Some care coordinators, a member has, such, complex needs and stuff like that, with their meeting weekly, and some it is every quarter. Really, there is no, beyond the minimum quarterly meeting, there is no sort of hard and fast rule of how often a care coordinator meets with a member, I should say, because it is so person-centered, and each person's services are so unique. Like I said, face-to-face have to occur every 90 days. And these are just some general good rule of thumbs to ask. Is the member satisfied with the services they're receiving? Are the services meeting the member's needs? Are the services being delivered as requested? And then ultimately, do services remain necessary for a member? This is a good time to go through all parts of the plan of care, review the goals, review what the member is needing. Maybe a goal needs to be expanded. Maybe it needs to be chopped off. Who knows? A lot can change in 90 days. And if you're curious about really getting into what a plan of care constitutes and what it goes into, I would again refer you to our trainings webpage and the care coordination training we have online. That really spends a lot of time delving into the plan of care, the different areas and stuff like that. A key part of care coordination responsibilities is ensuring that there's no duplication of services. This means is 1959 services, can't be provided to a member at the same time as another service that is the same nature and scope, regardless of source. This includes federal, state, local, and private entities. Medicaid is the payer of last resort. This means that if a member can attain a service through an alternative source, they are to do so before they get 1959 services. If a member is receiving services through, for example, a 1915C Medicaid home and community-based service waiver, example, the developmental disability waiver, the autism waiver, aging and disability waiver, the member must get services through those 1915C services before 1915I. An example of this would be, respite. If that's available, that's a service that's available through multiple waivers. Another example is the 1959 community transition services cannot be rendered at the same time as money follows the person because they have the same scope. The care coordination policy, again, goes into detail about this duplicative of services, what to do, what to look at, things of that nature. So we really stress people to read that policy and look at that policy in that section that talks about duplication of services first. Care coordinators help with eligibility redeterminations. Redeterminations need to be done 30 days prior to a member's current 1959 eligibility span ending. Members will receive a notice before it ends. And basically, best way I like to describe people is, the process is completely the same for redetermination as determination. You got to fill out the application, you got to do a HUDAS, you have to get documentation of the diagnosis, all that stuff, and submit it. And we say 30 days because, as you know, it can take a while to get all that information together. It's not stuff that you can usually do overnight, so to speak. There are 11 1915I services. Each service has to be tied to a SMART goal, which means it has to be specific, measurable, achievable, relevant, and timely. Non-medical transportation is kind of a unique one. It's really designed to it technically can be its own service, but it really functions the best when you feather it in and tie it with another service. And the example we use is housing support, where you could be providing the non-medical transportation if you're working with a member to look at potential places to rent, for example, things of that nature. There we go. Why is this not? I'm sorry. It's not. That's not changing up there. Let me hold on one second. It's not changing on the screen anymore. Slideshow. Why is that not? Okay. Can't get it to. Let me just do that and start over. I'm sorry about this. It's completely froze up on my side, my PowerPoint, so I need to close it and reopen it again. There we go. There we go. That's the slide I was trying to get to. It wouldn't go to that. So these are the different services under 1915I. Not all services are available in every county. We have a provider list that shows which providers are online on each county for each service. So you'll want to make sure to look at that list and see what county in question all right, so all right, I'm just going to do this because it's not 1959 services. This is how the services look. They get connected with the care coordinator, and then they go with the different providers the care coordinator connects them with. Again, as I said, we have a list of providers sorted by county and service. Members can choose the service provider outside of, they have to choose the service provider outside of their care coordination agency. Need to ensure services are delivered at home and community-based settings. Services are meant to be delivered at a member's home other than non-provider owned residential settings. And this is the responsibility of the care coordinator, and the care coordinator needs to know and understand the home and community-based setting policy. There's HCBS, home and community-based setting rule compliance verification. And then the different services, we'll just go through this here. There's peer support. These are delivered by trained and certified individuals in mental health or substance use recovery. They have to be certified as a peer support in the state of North Dakota before they can provide peer support services, and they have to maintain their certification. And again, on our trainings webpage, we have a link to the state of North Dakota peer support webpage where they can do all of those trainings and stay up on top of that. Housing support helps members access and maintain stable housing in the community. There's two components to housing support. There's pre-tenancy supports that help members secure housing, including assistance with benefits, applications, housing search, lease applications. And then there's tenancy support. So that's once a member is housed, this helps the member sustain their housing. This includes things like financial literacy training, educating on tenants' rights, skills training, dispute resolutions, all sorts of stuff. Employment supports and benefits planning. These are designed to help individuals developing long-term self-sufficiency with the myriad of different benefits and supports that they could need out there. This also includes helping members to obtain and keep competitive employment as well. As I said, non-medical transportation. This is to assess members, participate in their activities, and utilize community resources when no other sources of transportation are available. The key thing there is no other transportation sources available. We want to make sure that that we're helping members learn how to become self-sufficient and that they just don't become reliant and just automatically go for this as the default. Family peer support. This is for the members, guardians, and caretakers. This is to support them, because the philosophy behind this is if you support them, then the member will get added help and support. Respite services, short-term relief for caregivers of eligible members ages up to 20. Training and support for unpaid caregivers, financial assistance and caregiving education. Supported education supports members to achieve their education goals. And then community transition services applies to members transitioning from an institutional living setting. A key part of 1915I to understand is the conflict-free care coordination, and this is a federal requirement. This isn't state of North Dakota coming up with this. This is conflict of interest. This is stuff we have to keep in mind for CMS and for federal requirements, is that the eligibility, care coordination, and service providers are three programs that function separately. Now, what that means is if you're the care coordination agency and you're providing care coordination for a member, you cannot provide the same member with peer support or non-medical or a 1915I service. Another agency has to do that unless you get a conflict of interest exemption. And there are two of those. One is, let's say within that member's county of residence, you're the only provider that provides that service. So let's say in, I don't know, Ward County, for example, I was a care coordination agency and I was also the only entity that provides peer support services in that county. We would get an exemption for that, and then we'd be able to do both services. Or the other exemption is that within the member's county of residence, you are the only provider that services individuals based off of a common language or cultural background of the member. So when the member is looking for peer support and they say, I want a peer support, for example, that speaks Spanish, let's say, and in their county of residence, there's 4 agencies listed for peer support. In that referral to those other agencies, you would have to first ask them, looking for a peer support that speaks Spanish. If they all come back, no, we don't have a peer support that speaks Spanish, but we as the care coordination agency do, we would then get a conflict of interest exemption because the member has a common language or cultural background specific thing they're looking for. So it's all about what the member wants and needs and where and how that's available. And this is a good example of the follow-up of care. You develop the plan of care, receive and review monthly progress notes. You do your quarterly and interim meetings. Then you have your annual plan of care updates, and it continues on making sure the member gets the services they need. Up to 75% of care coordination can be done in a calendar month per telehealth, but 25% has to be done in person, and more specifics of that can be seen from our telehealth policy. Billing is done in 15-minute increments. This breaks down how that works, and because nothing breaks down exactly on the 15-minute mark. So this whole chart, and this is on a lot of our policies as well. We have 1915I, what we call provider office hours, on the first and the third Wednesday of the month at 9 a.m. Just have a Teams meeting where anyone can join in and ask about general questions, ideas, things that involve 1915I. We have a 1915I newsletter that goes out every month. We have them posted on our webpage, and also you can subscribe to it so you get it emailed to you. And it just gives you a good update on things that are changing with 1915I, hints, tips, things like that. We do a provider spotlight every month where we spotlight a specific 1915I provider as well, just to build a little community and things like that. This is our resources webpage. I'll show you that here in a little bit. Here's some one sheets that we have available for 1915I. And then there's just an FAQ part here. But what I want to do now, I don't know why that's there. Go. I'm going to show you our webpage real quick here. So that way you can see some of the things that I was talking about. And I'll also put it in the chat. That's their chat. So this is the main 1959 webpage. The presentation I went over. If you want this PowerPoint slide along with the narration, if you want to watch it at any time, it's right here. If you click on that and open it up, it takes you right there, and you can go through it at your own pace. You can zoom through it real quick if you want. So if you want to stop to it and come back, pause it, whatever, it's live. It's on our webpage. kind of just a very brief overview of the different services, how to apply. Then this right here takes you to the 1915I application. We are working on a how, like, this has the instructions. Well, first off, don't freak out. The application says 11 pages, but it's not, because pages, what is this? Pages 5 through 9 are nothing but the diagnoses, and then 10 and 11 are instructions on how to fill it out. So really, the application, if you really boil it down, is at most 4 pages long. So don't worry about that whole 11-page application. It's not 11 pages. It's really only 4. And the instructions are on there to walk you through that. We are working on a how-to, much like this presentation I have here, for the application. So that way, to help people walk through that. If you want to find a provider, it's this tab here. You click on that, open that up. As far as I see the question about providing supported employment, my first question would be, you'd want to check which county to look in. So for example, what the heck, let's go to Burleigh County. So I'd click on Burleigh County. First off, I'm showing you how to find a care coordinator. This is how you find a care coordinator. So you'd select Burleigh County, then you select whatever agency you're interested in, like Advocates for Change. Then it would show their information. And then it's like, oh, I want to look up someone else. So I'll look up them, and then the information changes. To reset the table, you just click this reset table button, and it resets it all back, and then you can check a different county or whatnot. As far as supported employment, that's what this table, or supported service support providers, that's what this table is for. So again, you would click by county. So let's do Ward County. So in Ward County, these are the services that are available in Ward County. So then you would just select, oh, I want to know who's doing peer support in Ward County. As you saw, this brings up the list there. And you would just select whatever agency you'd want, and then that gives their information here. So you can change that. You can come back here, select a different county. Let's check Cass County. So as you can see, Cass County's got more different providers online, so you can check there. So it all depends on the county that you have in question. And it's the same thing. So you can just click, as you can see, peer support has that, non-medical there, benefits, and then you would just, peer support, select one, and their information pops up on the bottom here. So that's how you look up service providers. The webpage that I tell a lot of individuals to check out is when you click on providers. This webpage has a wealth of information, how to become a provider, the trainings and information page that I told about, that takes you there. Our guidance and policy webpage. If you want any question about the policies that were linked in the presentation, they're all going to be here. The service policies, the care coordination policies, how to do the billing, because like right now you have to submit billing like you would like through MMIS or Availity, depending on expansion or traditional. All of our HUDAS guides on how to become knowledgeable and certified to do the HUDAS, we have that information here. Our THERAP how-tos for all of our providers, anything they need to know about THERAP is there, and any draft policies there. So this webpage here, the 1959 Provider Guidance Policies webpage, I've really recommend, that tells a lot of the meat and potatoes of the program. This training and information sessions, this is where you'll get the link to the office hours, our newsletters, here live on trainings opportunities. That's the link to the peer support webpage. Our on-demand training, here's that care coordination training I talked about. That if you open that up, it starts the care coordination onboarding training. Really just delves into super detail about care coordination training as well. We have the find a provider linked here as well. And then if you're just kind of curious of numbers of people who are on 1915I we have an enrollment data dashboard here where you can click on there. And then member enrollment, this will take you and kind of break down member enrollment for who's on 1915I over the last year or so. Breaks it down, traditional expansion overall, youth versus adult. So that's another area you can check out as well. And then if you do have any general questions at all, we always tell people to email our 1915I email, and I'll put that in the chat. It's nd1915i@nd.gov. Forgot the I. And this email is our general 1915I email. It's monitored by myself, Lori, and Alexis. So I always tell people if they have questions about 1915I to shoot that email your questions, because it's monitored by us three. So it's nice that it's monitored by three people. So it has a lot of eyes on it, but also it's still specific enough where, you know, it's just three people in it, not like half a dozen to a dozen or something like that. So that's 1915I. That's our webpage. I put that in the chat. So you got our webpage in the chat. The slide I went over is here. You can check that out. You got our email. You can shoot me an email, or the team, I should say, an email at any time. Otherwise, that is 1915I. Anyone have any questions? Are there places where we can send folks that are looking for specific guidance with filling out the application? For that, they can contact our navigator can help them. Let me put our navigators phone numbers in the chat. You can email us with questions. You can give us a call at those numbers. That's the same number. These are the same numbers that go out on approval letters for individuals. If they need help connecting with a navigator, they can do that. Or they can also go to the human service zones, should help them out. And also, I would think the human service centers as well.
Are there any other questions? Looks like Zoe did have one, but it was answered. Do you know which agencies are providing 1915I supported employment? And when you provided the link, she said that you answered her question.
Yep, that'll depend on county by county. So you just need to look it up on the find a provider.
Okay. Are there any other questions for Cody?
How recently does HUDAS or DLA have to be done within 30 days? It is within 90 days. That has to be done.
Okay, well, thank you so much, Cody. Thank you for presenting, and I'll let Kylie give the closing remarks of what we have coming next week.
Yes, thank you, Cody, for taking time out to present. Just another reminder, there'll be a survey sent out from Stacy, so please take a couple minutes to fill that out and provide any feedback along with any topics you might want to hear. Our next presentation will be June 10th, and this will be on media relations and how to handle media And then on the 17th, we have calming the stress response. And then to wrap up our spring session of trainings, we have on June 24th, we have evictions. So again, Stacy will be sending out a survey for this presentation and then reminders for the upcoming presentation. So hope you all can join us then. And I hope you all have a good rest of the day. Thank you so much for attending.